And thank you, Dr. Warren, for joining us this afternoon. I know you as a doctor's doctor. You've just stepped in fairly recently into the role, the first physician to lead Planned Parenthood in 50 years. And you are almost done, I'm given to understand, with a 5-month tour visiting Planned Parenthood affiliates around the country. So I'm going to start with an easy one, which is what have you learned coming from, as a physician, into this context, going around and visiting the network around the country? What have you learned that would surprise this audience of practitioners and physicians and experts in the system?
Sure. First of all, thank you for having me here, welcoming me back to Boston. This is where I trained at Brigham and Mass General, so it's good to be back with you all today. Thank you. And I appreciate the question about what would surprise people here. I'll tell you what surprised me. So I've been in my role now for almost 6 months, and one of the first things that I did was to start an affiliate tour, visiting our health centers. Actually, one of the things that people never talk about with Planned Parenthood is the fact that we are one of very few national healthcare organizations that has a presence in all 50 states. We have over 600 health centers with a commitment to serving the most vulnerable and a presence in all 50 states. And I just came back from a visit to one of our affiliates in Northern California. And they have had primary care there, treating newborn to 100 plus in this health center for over 25 years. And I saw how we were talking about maternal mortality earlier, and the care, the links to care that are missing for newly postpartum women. I learned that a postpartum woman can go in and get her own medical checkup. She can also have her newborn get the newborn well visit at that time as well. And also, if she's diagnosed with postpartum depression, there's a full-time mental health counselor in that clinic that she can go to for her care. And it's that idea of whole person care with full wraparound services. I mean, one of the nurses in one of our clinics said to me, illness is the easy part. Health is hard. And what we know in public health, that's exactly right. And I see Planned Parenthood as taking a very active role, not only in addressing healthcare challenges, but in meeting people where they are, addressing these social determinants, and really making it clear that when we stigmatize and specifically silo out one aspect of care, reproductive healthcare, women's healthcare, that's what leads to poor health outcomes. And actually, that when we do so, when we stigmatize women's healthcare, that's a tool of oppression and a tool of misogyny.
And I think that answer presages my next question, which is that at the same time as you, a physician, are leading this organization that provides care around the country, it's also an organization that's in the middle of a huge political fight and has been for the duration of its existence. So recently, the Trump administration, of course, has proposed a rule that is currently fighting its way through the courts on Title X, that you've made the decision that if this rule goes through, you at Planned Parenthood have made the decision that if this rule goes through, then Planned Parenthood would no longer accept Title X funds for its clinics. What was the decision-making process? What was it like within Planned Parenthood making that decision?
Well, I want to address your first point about the so-called controversy about our organization. And from my standpoint, we are not the ones that made healthcare political. You know, we're not the ones that made women's healthcare, contraception. I mean, it's 2019 and we're still debating birth control. Abortion, let's talk about this too. Abortion is a safe, standard medical procedure that 1 in 4 women will have in our lifetimes here in the US. And it must be understood as part of the full spectrum of reproductive healthcare. Reproductive healthcare has to be spoken as the healthcare that it is. We're not the ones that have made this a controversial issue. Title X is our nation's program for affordable birth control and reproductive health care, serving 4 million people, in particular women with low incomes, families who live in rural areas, who otherwise might not have any other access to health care. And the Trump-Pence administration issued this gag rule, saying that we as physicians and nurses and clinicians working in clinics that receive, health centers that receive Title X funding, we would not be able to provide our patients with referral for abortion care, even if our patients ask for it. And it's not even clear what we would do if it's medically necessary. I mean, this is a direct interference with the practice of medicine. And it forces doctors to compromise our ethics. I mean, I took an oath to provide honest, full, and accurate medical information to my patients. And this is the reason why over 100 provider groups, including the American Nurses Association, ACOG, the AMA, have spoken up in opposition, and actually we joined the AMA in a lawsuit against the Trump administration. And just last week, we received news of two preliminary injunctions to block the Title X gag rule from ever taking effect.
Some might argue that in some states, the decision not to accept the funds may force clinics to close. How did you factor that into the decision not to accept the funds if the gag rule goes through?
I apologize that I didn't answer your question the first time about the decision to specifically say that we will not accept gagged funds. Actually, for us, that decision-making process was simple, because for us, it wasn't a decision. We, as a healthcare organization, will never force our doctors and nurses to censor what they can say to our patients. I mean, for over 100 years, people come to know Planned Parenthood as the organization that provides non-judgmental, compassionate, high-quality care. And that care has to include all the information that patients need to make a decision. And so many of the questions around this have involved, well, what would this do? What would this rule do for our organization? And I respectfully would say, well, that's the wrong question, because at the end of the day, nothing that we do is about an organization. It's about the patients that we serve. And the fact that for millions of people, like my family, when my family and I first immigrated to this country, we depended on Planned Parenthood for our care. My mother was a patient of Planned Parenthood when she couldn't get care anywhere else. I was a patient of Planned Parenthood, and actually, as part of my affiliate tour, I recently went back to the same Planned Parenthood that I first got care at when I was a teenager. And to be able to do that and to be able to see the impact that Planned Parenthood has for families across the country, I just think it's important for us to take back this language, because, for all those who claim that they are pro-life, well, I don't know why they get to call themselves pro-life when we're the ones providing life-saving care every day.
Before stepping into this role, you were the health commissioner for the city of Baltimore. And one of my colleagues here at The Atlantic, Olga Hazan, wrote a story set in Baltimore, rooted in Baltimore last summer, called "Being Black in America Can Be Hazardous to Your Health." It was a great story, so I recommend it to all of you. And I wanted to ask this question about equity. One of the continuing disparities in the U.S. healthcare system has been on infant and maternal mortality for Black women and infants. Black women are 3 to 4 times as likely to die in pregnancy or from pregnancy-related causes as white women. And the U.S. is moving backwards on this front, and it's one of only 13 countries doing so. What do you see as, in combating something that is sort of system-wide, pervasive, and due to a really complex tangle of effects? How do you unwind something like that? And what do you see as Planned Parenthood's role in unwinding something like that?
Well, I was very proud of the work that we did in Baltimore specifically to address this. So in 2009 in Baltimore, we had one of the worst infant mortality rates in the country. And an African-American baby born in 2009 was 5 times more likely to die than a white baby. I mean, totally unacceptable. And actually, there were a lot of people who at that time said, this is a very complicated issue, and it is, right? I mean, there is the fact that in Baltimore, which I still am a proud resident of Baltimore, there are neighborhoods just a few miles apart where there is a 20-year gap in life expectancy that have nothing to do with access to health care per se, but are all these other social determinants that you all know, we all know very well. And yes, they are complicated, but there are things that you can do. And so we convened over 150 public and private partners in our city, hospitals, FQHCs, community partners, faith groups, and within 7 years of convening this group of specifically focused on one goal, reducing infant mortality, we reduced infant mortality in our city by 38% and closed the disparity between Black and white infant mortality by over 50%. And I think that's an example of what can be done if we focus on a common North Star and meet people where they are. I mean, some of these interventions included free crib deliveries, home visits to pregnant women, and really meeting people with the services that they need, connecting people to care. And as importantly, too, we specifically called out racism as a public health issue. And I think it's calling out the issues, not being afraid to voice the fact that there are structural barriers and inequities that have gotten us to where we are, but that there is a path forward, and that it's with that same approach that we do our work now at Planned Parenthood.
Yeah. Now, in just a moment, I'm going to turn to some of you for questions. So turn to the Slido system and start typing in some of the questions that you want to ask. But I have one more question for you before I do. So given the political context, with more and more states passing legislation that is making incursion on abortion rights around the nation, and with a lot of efforts that seem to point towards a Supreme Court battle over Roe versus Wade, what have the discussions been like within Planned Parenthood on what happens if Roe is limited?
It is a terrifying time for women and for healthcare in this country. I mean, we have Brett Kavanaugh on the Supreme Court, and as we speak, there are 15 cases involving abortion access that are one step away from the Supreme Court. So if any of them were taken up, we could have a real situation where Roe is overturned or further eroded within the next year. And if Roe is overturned, that means that 1 in 3 women of reproductive age, which is 25 million women, would be living in states where abortion is outlawed, banned, and criminalized. You know, I never thought that I would live in this world. I mean, when I went to medical school and residency, you know, this was not the world that I knew. I had mentors. One of my mentors practiced medicine in the 1960s and talked about how, at that time, there was a whole area in the hospital of the sepsis ward. But unlike the sepsis ward that I knew when I trained, it was full of young women who were dying from kidney failure and sepsis because they didn't have access to safe legal abortions. And I never thought that I would practice medicine in that world. But actually, this is what I'm seeing. This is the world that we could be facing right now. There are 6 states in this country that only have 1 provider left. There's a whole stretch of 1,600 miles between Idaho and the Dakotas that don't have an abortion provider at all. We have now 16 states this year in 2019 that introduced abortion bans at 6 weeks, when most women don't even know that we're pregnant. And by the way, some of these laws are so crazy that you'll have to look this up to make sure that you believe it. I mean, the ban in Ohio that the governor of Ohio signed does not have exceptions even for rape and incest at 6 weeks. Georgia's law that the governor could sign any day now allows the state to investigate women for miscarriages. Alabama's law would impose a 99-year prison sentence for doctors. And Texas legislators introduced a bill that would impose the capital punishment, death penalty, to women who have abortion care. I mean, this is the world that we live in, and this is why, as Planned Parenthood, we have to fight through our action fund with our legislators in the courts in every way against these bad bills. And at the same time, we have to be providing care. And, you know, I come from a public health background where, for me, this is no different than preparing for a hurricane, preparing for a natural disaster, except that in this case, that natural disaster is not natural. it's man-made. Well, person-made to be gender inclusive, but frankly, man-made. And I think that, I also find this to be so hypocritical because I look at these same states that have these laws that are coming out. Missouri, another state, I went to medical school in Missouri. There are terrible laws happening in Missouri, but look at what else is happening in Missouri. The rate of syphilis there has tripled in the last few years. There are 5 counties with a 1,000% increase in syphilis. Congenital syphilis at its highest rate in decades. And when we look at the rate of unintended pregnancies and when we look at teen births, we're actually at record lows for these around the country. The same politicians that are trying to restrict women's access to healthcare through limiting abortion access are also cutting access to birth control, are also changing the definition of evidence-based and cutting teen pregnancy prevention programs. So I think in the same breath, we also have to be calling out the hypocrisy and talking about how if people really want to be investing in preventing unintended pregnancies, preventing the need for abortions, and also improving health, they should be funding Planned Parenthood because that's the work that we do every single day around the country.
Now, this question from the audience is one that touches on the very first controversy I think I ever saw you step into, which was as the health commissioner for Baltimore, you prescribed naloxone to all the residents of the city, in part to combat another crisis, the opioid crisis that you saw unfolding on Baltimore streets. And so this question, opioid addiction, what role do medical professionals play in perpetuating stigma and eventually in eliminating it?
Great question. And you mentioned in Baltimore about the work that we did. I actually have several members of my team who came with me from Baltimore here who are very involved in this work. But I am. In coming into my role in Baltimore, I knew that opioid addiction was something that affected every aspect of our city. And people were dying at unprecedented numbers. So I issued a blanket prescription for naloxone, Narcan, to every single resident, which is a little bit scary to write your NPI number and your signature on for 620,000 people. But actually, as a result of that blanket prescription and our outreach, everyday residents saved the lives of nearly 3,000 other people in Baltimore City in just 3 years.
What did you learn from that decision that carries over into your work now at Planned Parenthood?
First, that you have to be bold. That when there are people dying who need us now, we have to take bold action, and we cannot wait for perfect. Perfect is the enemy of the good in cases where there is a life-threatening public health emergency. Second is that you gotta start somewhere. I knew that naloxone, it's a short-term solution, right? It's an antidote. And that person still needs to be connected to longer-term treatment. But if somebody is dead right now, there's no chance for them to have a better tomorrow. And that's also a part of what I bring into this work. And I would say, too, that the other thing that we bring into our work now is specifically around opioid addiction and around behavioral health, that every interaction is a point of intervention. And so you'll see more in months to come about the work that we're doing and that we're looking to expand, including in mental health, including in the opioid epidemic, including in other public health issues like food security and housing. These are things that affect everyone, and all of us have a role to play in promoting health equity and really bending the arc of our universe back towards justice.
Please join me in thanking Dr. Leana Nguyen for her contributions this afternoon.